I'm here to introduce the presentation of Dr. Lynette Abrams-Silva. It's really a pleasure to introduce Dr. Abrams-Silva. She is one of my mentees, one of the mentees that I'm extremely proud of mentoring. She is a native New Mexican, board-certified clinical neuropsychologist, and she's the director of the psychology clinic at UNM and oversees everything that's going on there and supervision of pre-doctoral students and some postdoctoral students. So she's doing a lot of work to try to improve access to neuropsychology in our community, at least for the future. Dr. Abrams-Silva provides comprehensive clinical and forensic neuropsychological assessment for adults also in the community through a private practice. She earned her doctorate in clinical psychology from the University of New Mexico with a specialization in neuropsychology, completed a pre-doctoral internship at the University of Chicago, and a 2-year fellowship at the University of Illinois at Chicago. Prior to her current position here in New Mexico, she held the position of Assistant Professor of Psychiatry at University of Texas Southwestern Medical Center in Dallas, serving concurrently as Director of Assessment for Parkland Hospital Psychology Service. Dr. Abrams-Silva has become extremely active in professional organizations. Particularly, she serves on the board of directors for the American Board of Clinical Neuropsychology, which is the board certification organization for neuropsychologists. And she has also recently become a board examiner for that certification. So I don't want to take any more of her time. I'm very excited about her presenting some data about COVID, which is obviously an extremely timely project. Please welcome Dr. Lynette Abrams-Silva. Take it away, Lynette.
Thank you, Dr. Holland. That was a very nice introduction. I am, now that we have set up my ability to share my screen, I'm going to share this presentation, and looks like it's all good to go. Yes, so thank you for having me here to talk about the neuropsychology of COVID-19. I am going to talk a little bit about some of the emerging trends that we're seeing in research, but also how that plays out in our local population. I can now advance my slides. Yes, I can. So first, I am going to present some of the highlights of the current research, and then present a few cases that sort of represent well what I am seeing clinically. And then I will end with a little brief presentation about what I have done working with the long COVID clinic at UNMH. What is the current state of research when it comes to COVID and neuropsychology? I think we all have seen in the clinic, various clinics in our various specialties, that people who have had COVID, whether they have recovered or they are reporting persisting symptoms, often report they have cognitive difficulties. So we've started looking at that, but I do need to give some caveats because this is a nascent body of literature. Obviously, we've only been able to study any of this since 2020 and under the most unusual of circumstances. I'm ready for not living in unprecedented times anymore. I could use a little precedented at this point, but we are looking at science that has evolved under unusual circumstances. And longer term outcomes of having COVID or long COVID or recovering from COVID, all of that, we don't know yet. We are still pretty early post, if we can call it post-COVID. Therefore, some of this contributes to the varying methods that we see in this growing body of literature. Some are very small populations that were studied, some were larger. They tend to be small studies with comprehensive neuropsych evaluations or very large studies with cognitive screening. So they don't necessarily, it's not a cohesive body of literature yet. We also, because of the necessity of having to isolate from each other, some of this research, the data was gathered in person, and some of the research was gathered via telemodalities. And we do have some research that some of our measures have equivalence in person and tele, but much of our what we do in neuropsychology does not have equivalence, and that introduces variability. So that variability plays through in the research that we have collected data in this way. Plus, methods studying constructs like memory and language always vary, whether it's about COVID or whether it's over telemodalities or not. And I just want to give a little reminder, anyone who has worked closely with a neuropsychologist probably hears us say very frequently, our measures are sensitive, but they're not specific. It is the overall cognitive profile that is specific. And so when we're talking about a memory problem or a language problem, neither of these constructs are individual processes, but they're made up of many different processes. So deficits in other cognitive domains can show up as lower scores in these areas. So a memory problem could actually be due to poor attention or working memory or executive deficits. And language problems could also be seen on testing, but accounted for by executive problems or processing speed slowing. And so within the literature, sometimes it is not clear what is meant by the construct of memory. And populations vary. I think that everyone in New Mexico recalls that particularly our reservation populations were hit very hard and had extra factors that they had to experience related to the pandemic. These vary widely. So the experience of the pandemic and how the virus was managed in various communities and countries around the world can be very different. And then just at baseline, there are global differences in how we assess cognitive functioning. So it's not, again, a perfect and cohesive and large body of literature. So just keeping all of those in mind, I know the burning question on everyone's mind right now is, okay, what do we see? What kinds of cognitive deficits do we see in sort of post-COVID presentations? Most frequently, we are seeing difficulties with attention, working memory, processing speed, and executive functioning. And there is some research to suggest that executive functioning is the most consistently and frequently observed cognitive deficit. Now, even all four of these difficulties together are somewhat non-specific. Attention, working memory, processing speed, executive functioning, all of those can be seen in a number of conditions: vascular cognitive impairment, sometimes moderate or severe traumatic brain injury, sleep disorders, various medical conditions. So what disease factors do we think are related in the COVID-19 population? Who gets these deficits? What predicts them? Is it specific to the virus or the course? What is it? What are we looking at? And the research is pretty interesting, if somewhat inconsistent at times. You have to forgive me for not putting all of the citations in here. It just got too crowded. So yes, I opted for visually appealing rather than informative for this slide. Some factors that seem to contribute to who gets cognitive deficits at the end of their course of COVID. Symptom severity has been found to result in worse cognitive problems, especially executive functioning. But mood symptoms seem to be worse with mild symptomatology. Attention and executive functioning have also been found to be worse in severe symptomatology from COVID. However, memory, and again, not sure what part of memory, processing speed and fatigue have been found in mild or asymptomatic patients. So symptom severity is sort of, you can apparently have cognitive changes secondary to mild, moderate, or severe COVID. The symptom type does seem to be pretty informative. These particular symptoms are associated with worse cognitive outcomes, and some of them make sense, particularly delirium, systemic inflammation, time in the ICU. Some of those are not COVID specific. Some of those are related to any illness. But one of the things that was interesting in this body of literature is the olfactory dysfunction. I know that was highlighted early on as being a neurological symptom. And of course, there are other neurological symptoms that are associated with COVID that do predict poorer cognitive outcomes. But olfactory dysfunction seems to be pretty strong, a strong predictor of cognitive problems later. Demographic factors are also somewhat informative, but again, also a little inconsistent. Persisting psychiatric symptoms are more frequent in females with a positive psychiatric history. Persisting cognitive symptoms are related to females just can't catch a break here, and being older. However, there's also some support that being younger predicts cognitive problems associated with COVID. And again, sort of nonspecific and associated with many conditions, lower levels of education and lower levels of socioeconomic status predict worse outcomes cognitively. Plus, pre-COVID health factors, certain pre-existing health conditions and risk factors, especially vascular in nature, a psychiatric history, and then luckily we do have some protective factors that we can say it seems to be mitigating in terms of cognitive function. Vaccination, if you had COVID and you were vaccinated, less likely to have cognitive difficulties afterwards, and cognitive reserve, which goes along with the opposite, being lower levels of education and socioeconomic status predict poorer outcomes, and cognitive reserve, which we usually measure by way of educational attainment and premorbid intellectual functioning, are protective factors for developing cognitive symptoms associated with COVID. There are some hypotheses regarding the mechanism of these changes, or even what is being impacted. One is that there is limbic system involvement, that the limbic system is particularly sensitive to some infections, and we have seen that in the past, like herpes encephalitis tends to go straight for those hippocampi and eat them right up. And so the theory being perhaps this specific virus is also particularly attracted to the limbic system. One very popular theory is persistent neuroinflammation, much like chemo fog. Then, of course, exacerbation of subclinical neurocognitive and motor disorders already present. Perhaps something is emerging, and having COVID accelerates that emergence of whatever was going to emerge anyway. And then the autoimmunity, autodeficiency change that we also have seen with other viruses, that a virus can either hasten the onset of an autoimmune condition that was there, or sort of exploit the tendency to have that autoimmune condition. And we've seen that again too in viruses like Lyme disease. We don't know for sure what the case is for these mechanisms of injury, but these are some leading hypotheses into how we end up developing these problems. Some of the really interesting results that have emerged in this literature are that cognitive impairments appear most pronounced in those who have been hospitalized, but you can also see them in those who have not been hospitalized. You can see them in mild cases and even asymptomatic. So again, we can't necessarily say that disease severity will absolutely predict developing cognitive symptoms and the degree of those cognitive symptoms. We have found that the same or worse degree of anxiety and depression that among non-hospitalized compared to those who were hospitalized. So some higher rates of mood symptoms in non-hospitalized patients. There is a phenotype hypothesis, which is pretty interesting. This particular group found that anosmia and symptom severity predicted memory difficulties, processing speed difficulties, and more severe fatigue, and just overall poorer outcomes, whereas pre-existing health and socioeconomic status predicted difficulties with executive functioning. And this, if this is something that we're going to see, different phenotypes, that could be clinically useful in the future. There isn't much follow-up to this yet. Obviously, this article was published this year. So I don't know if anyone is looking to do more research on this, but this sounds like a promising, useful type of hypothesis that could be used in the clinic. Because, as I said, symptom severity doesn't seem to predict who will get cognitive symptoms and who will not. We're also finding that PTSD is more frequently seen in ICU survivors, and PTSD itself can independently impact cognitive functioning. So this could be related to some of the cognitive changes that we're seeing. So as you can see, and you probably already know from experience, there are many aspects of this virus beyond just the virus itself, including the experience of the pandemic, pre-existing factors, and a lot of things that are likely contributing to a very complex set of clinical presentations. And I have a fabulous infographic that I'm not going to go into great detail about, but I think it just even at first glance gives us the idea of all of the factors, maybe not even all of them, but many of the factors that are associated with this pandemic, not just the virus. And there's this, intersection of an illness and the environment in which we have experienced the illness. And I've just sort of highlighted that this is a multi-level framework describing the biopsychosocial interactions potentially influencing cognitive performance in post-COVID-19 syndrome. So it's not to sound like a total psychologist about it, but it's complicated, right? There are a lot of factors to consider, and they're, actually interrelated in a really interesting and possibly frustrating way in that, are they bidirectional? Do we have a big cyclone? We know that executive functioning difficulties, there's some support that these are the most frequently seen in a post-COVID population. And executive functioning difficulties exacerbate and are exacerbated by mood symptoms, poor quality sleep, and fatigue. And those factors exacerbate each other. So we end up getting like a system of dysfunction where perhaps the first symptom is the executive functioning problem that then exacerbates mood symptoms, that makes sleep difficult, that contributes to fatigue, that impacts that executive functioning more, which worsens the mood, and so on and so on. And this type of cycle of exacerbation may be why some patients report worsening cognitive symptoms after the virus has already resolved for them, because there are now these additional factors. We've triggered the cyclone of symptoms. So it's safe to say that there are many factors to consider, and this is a growing body of literature that is starting to illuminate how these factors interact with each other and how that appears clinically. However, how does this all present in our particular patient population? Because every calculation based on experience elsewhere fails in New Mexico. That was Lew Wallace, who was governor when we were still a territory. We are a very unique population. We are somewhat isolated from the rest of the world, even the rest of the Hispanic world being a minority majority state. We have an interesting regional setup with lots of rural areas and space in between, not a lot of resources. And so we're pretty unique. I think everyone who is a clinician in this community has experienced how unique we are. So we know some things about what cognitive functions are impacted and some of the factors that contribute to why based on the literature, but what are we seeing in our local population? I have 3 cases that I will briefly present that are not unusual. These are actually trends that I am seeing in our population. The first one is the case of a 33-year-old right-handed Caucasian female with 18 years of education. She had COVID in March of 2022. No hospitalization, no complications. As far as we know, no drop in oxygen levels. She reported 8 to 9 days of symptoms, stating that the first symptom was loss of taste, then cough, fever, and fatigue. And she characterized fatigue as the worst and most significant symptom. She also reported that the other symptoms resolved, but fatigue did persist. Other persisting symptoms she reported were attention problems, memory problems, slowed thinking, word finding problems, just a sort of overall brain fog, disrupted sleep, and of course, fatigue. Looking at her history to see if any of these pre-existing factors that we were just talking about were impacting the trajectory of her recovery. Developmental history was fine, nothing to note. She was actually otherwise a very healthy person. She only ever really had seasonal allergies, and the only medication she was taking was bupropion. She did report an interesting psychiatric history, characterizing her history of treatment as a carnival of SSRIs in the past, which she stated that she was diagnosed with depression secondary to religious trauma. She was raised in a very stringent, maybe a cult-like sort of atmosphere, where she was controlled, and maybe emotional abuse was part of it. And so until she got out of that environment, didn't think anything was different, and developed depression once she separated from that community, and stated that she's been stable ever since. Really doesn't use substances, no history, just the occasional glass of wine. And when asked, said that her family history was really only remarkable for Parkinson's in her paternal grandfather. So not a lot, maybe some, we have female sex and we have a psychiatric history, and that, as we know, has been shown to possibly predict cognitive changes. So maybe this is just COVID, simple COVID, right? Maybe not. She has some new symptoms that she didn't have before COVID. She's experiencing dizziness. She's got some orthostatic hypotension, stands up, gets lightheaded. She's developed GERD and some GI issues that she didn't have before. And she has joint pain now, daily, which is new. 5 out of 10 average daily pain intensity, but she says it's worse with stress. And she really does experience stress. She got lost on the way to the clinic that morning, the day of the evaluation, and was crying and hyperventilating, and our admin had to sort of talk her through how to get there. And when she came in, she said that her joint pain was much, much worse because of the morning's confusion and feeling upset about it. But then she did manage to sort of regulate herself and calm down. She said that she's been bumping into things a lot and never really did that. And she's bruising herself very easily. And she reported sleep initiation problems. When asked, okay, what keeps you awake if you have difficulty falling asleep? She said she worries a lot. She also loses track of time and sort of forgets to go to bed at a reasonable hour. And so to combat this, she started taking Benadryl every night for sleep in the summer of 2022 after she had ostensibly recovered from COVID. So what does she look like on testing? Her current cognitive profile, she did demonstrate highly variable processing speed and working memory and very mild executive functioning inefficiencies. Also very unusual outside of the context of, say, an Alzheimer's pathology. Her semantic fluency was much worse than her phonemic fluency. And this is a patently abnormal pattern. Human brains aren't meant to function this way. We organize things semantically in our neural network. If you are thinking about items of clothing, you've activated a semantic network for items of clothing, and that information should be easier to access than if I ask you to give me all of the words that you can think of that start with a particular letter, because we don't file things away in our brains alphabetically. That would make us all very inefficient if we had to get information alphabetically. So this pattern is very atypical, and in someone this age, very unusual. And she also, when measured, she did report mood symptoms, but no more than average when compared to a chronic pain population. So maybe all of this is due just to COVID, the virus. It's probably not entirely due to mood or pain, but that semantic phonemic fluency pattern, we see that in younger folks with sleep disruption. And she is reporting sleep disruption, and she's reporting nightly use of an anticholinergic. And those two things together can look like this. We can see this sort of semantic fluency issue in the context of that. But there's still something else I can't quite put my finger on, just looking at this pattern of performances. And there is something that I sort of held back from you about the history, because the patient held it back from me, not on purpose, but I did end up at the end of that interview pulling a Columbo and, hand on the door, ready to leave, ready to get ready testing, get it underway. And I said, one more thing. Are you sure that no one in your family has any sort of history of an autoimmune condition like lupus or MS? And I give some examples. And the patient says, oh yeah, my sister just got diagnosed with Ehlers-Danlos through genetic testing. Well, this allows me to update my hypothesis. Now my hypothesis is that she had COVID-19, which maybe hastened the onset of an Ehlers-Danlos that was going to emerge. Or maybe, given her age, she's in her early 30s, she's Caucasian, maybe she would have developed it around now anyway. But she also has some sleep issues, and I can't rule out the idea that COVID contributed to all of these things. Interestingly enough, Ehlers-Danlos has been shown to be associated with working memory problems. So now we have an additional possible contributing factor that is not exactly COVID the virus, but may be related to COVID the experience. And so the recommendations here that I provided the patient were to follow up about possible Ehlers-Danlos now that we have a positive family history confirmed by genetic testing. and then consulting with her referring about the possibility of getting a sleep study and discussing that nightly use of Benadryl, because the two things together do appear to be impacting her pretty significantly on cognitive testing. This is not an unusual type of patient. Caucasian females in their 30s, which, if you think about base rates and what tends to emerge anyway, Caucasian females in their 30s, autoimmune conditions. So it's possible that what I'm seeing in the clinic goes along with the autoimmune hypothesis in the literature, that perhaps having COVID either hastens the onset, or it could coincide with the onset, or it could cause the onset of an autoimmune condition. And I've seen this a number of times. The second case is a 55-year-old right-handed Hispanic male with 12 years of education. I always ask the same question at the beginning of an evaluation. What is your understanding of the reason for today's evaluation? And he said, I don't know. My PCP said I was having forgetfulness, which is not something I usually hear. Usually I hear that someone is forgetful, not that someone's doctor has told them that they are forgetful. So, a little bit more questioning. He did have COVID early on, before there was a vaccination available. He was hospitalized and he was intubated, and he did have low oxygen levels. He spent 25 days in the ICU. He was discharged to inpatient rehab for 13 days. He spent 17 days on a ventilator, and his oxygen levels were recorded in the low 70%. So this seems like it would predict, if we go with severity of symptoms and stay in the ICU, we can say maybe this is going to be the type of patient who will have COVID-related cognitive changes afterwards. But he's not saying that he has persisting symptoms. He says, yes, I had some brain fog during COVID, and after I recovered, I have mild brain fog. He said it's getting better though. And he said he has persisting shortness of breath. And that's it. He's really not reporting any other symptoms. And throughout the interview, didn't really seem to think that he needed an evaluation. Felt like he was doing just fine. And really, his history, developmental history, was negative for any concerns or contributing factors. He did have some vascular risk already. He had elevated A1C, so he'd been told he had pre-diabetes, he had hypertension, and he had a prior sleep study that indicated mild obstructive sleep apnea, so mild that they did not recommend any sort of intervention, so no CPAP. And this was quite a while ago. This was pre-COVID. Psychiatric, denied any history, denied any symptoms. How would you say your current mood is? It's good. Great. All right. So we can just forget mood as a contributing factor, right? Because the patient tells us they don't have any mood symptoms. No substance use history except for remote cigarette smoking. He quit 30 years ago. Nothing recent. Family history, remarkable for some of that vascular risk, type 2 diabetes and hypertension in his mom. So again, he's really only reporting mild brain fog and shortness of breath. And when I test him, working memory and executive functioning are down. They are weaknesses. Processing speed is a strength. That's unusual. I would not necessarily expect processing speed to be a strength. We've seen in the literature that processing speed is often impacted due to COVID, but also it's usually impacted by vascular factors, and he does have vascular factors. Plus, that complications of COVID, hypoxia or anoxia, that also often impacts processing speed. And we've seen from the literature that COVID can impact processing speed. However, here it is a strength. In addition to this pattern, he demonstrated a pattern of significantly better performances on similar but harder tasks. So, we often have measures that use the same setup but are increasingly difficult. And human brains, if they are functioning the way we expect, will produce intact cognition and will struggle more with harder tasks. And this was the opposite. This was lower scores on easier tasks, which, he is denying mood symptoms. And I mean denying mood symptoms. He says his mood is good. Every questionnaire, he is giving me goose eggs, 0, 0, 0, no symptoms, nothing. But this pattern of performance, of better performance on harder tasks, really suggests to me that there is more mood symptomatology than he is reporting. And again, I have done a little bit of a trick, and I've held back a piece of information from the interview, which was his mother and his uncle died of COVID while he was hospitalized. So overall, yes, he's reporting shortness of breath that has persisted. He probably could use some pulmonary rehabilitation. And I recommend a reevaluation of that sleep apnea to see if he, at this point, could benefit from a CPAP, given that he now has had at least hypoxia and he's having shortness of breath. It seems like a CPAP might be in order, or some other intervention at night. But given evidence of greater mood symptoms than reported, and this big loss, particularly while he was hospitalized, so he didn't know that he had lost these family members until he was discharged to rehab, he may benefit from some sort of psychotherapeutic intervention if he gets to that point where he's willing to engage in some sort of psychotherapeutic intervention. And this is where, in a neuropsychological evaluation, the feedback is so important. To have a conversation with the patient and say, I think that you have some mood symptoms. I think you have some depression because of what has happened that you might not be completely aware of, or it might be hard for you to really look at right now because this was very traumatic. And if you can get someone who is sort of hesitant, just to say that they're open to it, I consider that a pretty good day. So hopefully this patient will actually pursue some of that, but was open to pulmonary rehab and getting that sleep study, updated sleep study. And case 3, very specific to our local population. I saw a 38-year-old right-handed Navajo female with 14 years of education, diagnosed with COVID in January of 2021. This is a Navajo female from one of our local reservations. And as you probably recall, our reservations were hit very, very hard, and not just with the sickness itself, but with lockdowns, and to the point of roads that were closed, and law enforcement involvement, and we suffered a lot of loss there, many deaths. And this was one of those cases that this whole entire family lived on one of our reservations, and one family member just infected everybody. There was a gathering of this large family, and she said it spread very quickly through the family. She tested positive at one of the rural urgent care facilities. Her oxygen was measured at 86%. And at that time, we were still airlifting to UNMH, but she declined and waited 5 or 6 days but eventually was worsening, and so she was airlifted to UNMH. She was ventilated and sedated, but they had very limited options in treatment at that time, mostly because she was 8 months pregnant. So you can imagine how this experience was very different. She had some complications during the course of hospitalization. She was told that she was on a ventilator, but it wasn't helping. So she had a blood transfusion. And then she was told that the baby was restricting her lung capacity. So while she was sedated, they performed a C-section and the baby was fine. But she woke up 3 weeks later, not pregnant and not having any idea what happened. So this was, as you can imagine, very, very traumatic for her. The plan was to discharge her to inpatient rehabilitation, and she said, "I forced myself to not go to rehab." She had a pretty strong mistrust of the medical system, which is not unusual in our Native populations, and she denied any current symptoms. She denied any contributory history, although with medical history being somewhat unknown because she avoided engaging with the medical system. I'm actually thrilled that she decided to come in for neuropsych testing because of her deep mistrust of the system of healthcare. And when I tested her, obviously in this population, our measures are less appropriate. They can tell us less. We have limits to our ability to assess this kind of cross-cultural gap. But we also don't want to become another barrier to care. So working very hard my entire career to maintain and build additional cultural competence. I was very careful in the measures that I chose, making sure that I chose an appropriate test battery for a Navajo female with a reservation background. And I did find that her executive functioning was down on testing, and so was confrontation naming. Confrontation naming is, I show you a picture of something and you tell me the name of the thing. That's usually spared in insult or injury, unless you have a very focal injury. Confrontation naming is pretty resilient to any sort of problem. Now, it could be that there's a cultural impact on that performance. So I have to consider that. But looking at her vocabulary, which I also measured, her vocabulary was average. So again, I can't rule out entirely that there was some impact of culture and education. But given that vocabulary was average and confrontation naming was impaired, and knowing a little bit about her background, I actually believe that what I'm looking at is real and not just a bias of the measures I'm using or the methods that I'm employing. I also did my best to use a better confrontation naming task. We do have a very solid naming task that is sort of the gold standard. You might have heard of it, the Boston naming test. But it is also the test we have that has the strongest correlation to education. So in this population, I tend not to use it. I tend to use a different naming task that has been shown to have less of a correlation with education. So while I'm very cautious about saying I think this deficit is real, in the grand scheme of things, in the big picture, I believe that there is an issue there. And I think that that's some evidence that she had a hypoxic event. I mean, she did have hypoxia, and now we see sort of evidence of the cognitive sequela of that. In addition, these were not impairments, but her processing speed was significantly better than her working memory. Again, surprising because she has a number of factors that I would expect to impact her processing speed, but it's actually a strength on testing and better than her working memory, which is a bit reduced. This pattern, and actually, I guess I have to give Kathy Holland credit for this because I think looking back, I learned this from her about TBI and PTSD, and that this pattern is much more frequently seen in PTSD. The theory being that processing speed could represent a bit of that hypervigilance. Of course, this is a very sensitive topic within this culture. She denied mood symptoms, and there is a sort of built-in cultural avoidance with the Navajo population. However, given everything I know about this course of medical complications, particularly that experience of birth, I do suspect PTSD for this patient. This is always the challenge. About 11 or 12% of my patient population are Native, mostly that's represented by the Navajo population. And I see PTSD in some of my Navajo patients, and it is a challenge because our most efficacious treatments for PTSD are exposure, prolonged exposure, where you talk about the details of the trauma over and over again, and cognitive processing therapy, which is similar, you just write about them over and over again. And in the Navajo culture, that's exactly what you don't do. So neither of our interventions that we know to be efficacious, that are supported by science, are necessarily going to help someone from this background, given that it is actually taboo to talk about negative experiences. I also have the problem to overcome of well-founded mistrust of the medical system. I would actually like her to engage in some pulmonary rehab. She never had any rehab, and I would like for her to have some follow-up care, but she really is resistant to doing more with the medical system than she has to. So maybe gently suggesting engaging in some rehab would be useful, and hoping that plants some seeds. And having a conversation that I've had many times before with many Navajo patients about seeking, establishing contact with a traditional healer, particularly if they are from a particularly traditional background. This gives them some support to address in a culturally appropriate way the experience that she's had. And I don't want to give 20 recommendations to this patient from this background. I don't think it's that effective to give someone 20 recommendations that they're not ever going to follow up on. So for this patient, these were literally the only 2 that I gave in that feedback session. And I spent 90 minutes, which is a lot longer than my usual feedback session, just discussing in the most culturally sensitive way I possibly could what I thought was going on and what I thought might help. So 3 very different patients, but all representing a large portion of our patient population, and in each case, not unusual in the patient populations that I've seen that have had COVID. So I have just a brief ending to this presentation, which is about adapting to a post-apocalyptic landscape. I know it's very dramatic to say that we are in a post-apocalyptic landscape, but there's really no denying that the pandemic has changed all of our lives, and especially in healthcare. Adapting to be the most efficient and effective within this shifting landscape is absolutely necessary. And if you have worked with neuropsychologists in the past, you will know and deeply appreciate that we write very long traditional reports. We include a lot of detail about history, incorporation of available medical records, long descriptions of test scores and performance patterns. And typically, if you have a report style as a neuropsychologist, in the past, we've had one style for every referral source, every referral question, and that's how we've done things. And I believe, as a neuropsychologist, there is still a place in healthcare for this traditional approach. Certainly, I've been a big supporter of how we've always done things, but particularly in our community with overwhelming need, few resources, and again, a very unique and diverse population, I find there's no other choice but to adapt. And so I have worked very closely with Dr. Alicia Parada in the long COVID clinic to adapt my contribution to her specific needs and the needs of her patients. Then I just realized I'm about to show you this extremely short work product right in front of Kathy Holland, local neuropsychological legend. And suddenly I'm a little bit nervous, but I'm going to take a deep breath. And I'm going to show you this 3-page report that I worked with Dr. Parada to develop to best take part as a member of that treatment team. Even my PowerPoint is nervous. There we go. All right, so this is the 3-page report is not meant to be read. It is de-identified. I just wanted to point out how I've structured this based on the input from the referring physician. There's still very specific, demographic information that needs to be included, the reason for referral, and then I just jump right into summary and conclusions. I've never taken it personally. I know most of you who have read neuropsych reports flip to the end for the summary and conclusions. So I just put them up front for you, just right there, with 1 page of what I think is going on and a diagnosis, followed by the recommendations that I think are appropriate. And then just because of my own need to support my opinion, I put in some relevant background information. This is also where I would put relevant behavioral observations, just the most relevant details, followed by a table, a list of tests administered, and a table describing the patterns of performance. And that's it. Because this is for a specific clinic. I've also not adapted to a shorter battery for this population. We don't know enough about COVID to adapt to a shorter battery. And I am working with 2 other sites, one in Minnesota and one in Chicago, on collecting data from a specific test battery that is rather long so that we can learn more about this and in different regions of the country. So that the test battery is still comprehensive, and it's the same battery that multiple sites are using, but it is fixed flexible, meaning I will adjust when necessary, particularly to uphold this idea of cultural competence and sensitivity. Some tests are going to be more appropriate or less, depending on the background of the patient. I did work with the referring very closely to determine exactly what she needs to know. And that includes, what do I leave out? Because a lot of that history she knows already. Why would I want to tell the referring history she already knows? So I leave out a lot of that because she's the one that's providing it to me. I still do feedback with patients about their test results, although I do add that I'm just a member of this team and that a lot of what is going to happen next regarding care will be coming from Dr. Parada. But the focus really is working as a member of the treatment team, and that has allowed me to write a shorter report, do this efficiently, and see more patients. And additionally, of course, I am open to further adjustments to the report to make sure that I am best serving the needs of that particular referring physician. So does it work? I hope the answer is yes. It is working. At least I feel like this has enabled me to be more efficient, and the referring gets the information she needs. And yes, I do feel a bit strange whenever I write something this short, but adjustment takes time. I wanted to leave a minute or so, however much time I have, for questions. And if I don't get to them, you can always email me. I'm always happy to talk about this stuff. I live for it. So there is my email address.
All right. Thank you. Thank you, Lynette. Does anyone have any questions? Just jump in.
Hey, Kathy, this is Jennifer Crawford.
Hey,
Dr.
Jen.
Abrams-Silva, so wonderful to have you presenting today. I was just wondering if you could say a little bit more about how the collaboration with the COVID clinic came about, because you're a pretty busy person, and I'm just wondering how you're fitting all that in.
Well, like I said, post-apocalyptic landscape, I got a referral from the long COVID clinic. I happen to know Alicia Parada from just the community, and she sounded sort of desperate in her referral. And so I called her and said, what is it that you need? And if you're running this long COVID clinic, you probably have a number of patients that need to be seen. And she said yes. And so, we went to happy hour and we had a conversation, and I asked her all of the questions. What do you need? How do you want this to look? And it actually, if you put in that effort up front, then yes, I'm drowning in work right now, but putting in a little bit of work up front enables me to be more efficient down the road. So I'm willing to do that, lose a couple of nights sleep just so that I can see more patients in a more efficient way down the road. And I try to be very loud about my presence in this community so that anybody who has any questions about neuropsychology ever will feel free to reach out to me and at least have a discussion about what their needs might be. So I'm still available to do this, even though I have promised my mentor, Kathy Holland, not to do too much. I think we both agree this is necessary.
Any other questions?
Dr. Abrams-Silva. My name is Teresa Gomez, and I'm from the Pueblo of Isleta, and I'm a lecturer too at UNM's Community Behavioral Health. And I just wanted to thank you for acknowledging the cultural considerations, especially in your case number 3 with the Navajo woman. That was outstanding, and I think we need to see a lot more of that in treatment with our Native populations, that we come to the table with many considerations that are really outside the norm, and just your acknowledgement of the tools that are used that are not culturally appropriate if in some ways, or you may not get the results that you're thinking or that you may otherwise get. So I just wanted to acknowledge that, or to thank you for acknowledging all of that and really bringing it to the forefront.
Thank you. I shouldn't, frankly, I shouldn't be the one doing these evaluations. I want a team of Indigenous neuropsychologists. I'm just holding a place for them. I want to train them. So like anyone who needs training, I'm happy to, again, don't tell Kathy Holland, because that's more work that I said I wouldn't do, but again, necessary. And that's my goal, is to train Indigenous neuropsychologists so that they are actually the ones doing this. I'm just a placeholder.
Well said. Any other questions? We have another minute.
Yeah, I have a quick question. I'm curious whether, sorry, I'm Danielle Rivera. I'm a psychiatry resident, and I was curious. I know this has kind of primarily been focused on COVID, but whether or not there have been any comparisons to trends with other post-viral syndromes like myalgic encephalomyelitis or anything like that, because roughly about a third of people with long COVID tend to meet criteria for that diagnosis, and whether or not there's been any sort of comparisons or use of that literature to inform current practice.
There has actually Lyme. There has been some comparison to Lyme disease in that there seems to be a delayed response that might not be obvious, like suddenly there is chronic pain. Or suddenly it has triggered something, some process that may or may not have been triggered by something else. So I think that starting with Lyme kind of makes sense to me. I'm hoping that more will be looked at. I particularly am interested in the autoimmune component. Autoimmune conditions are sort of my favorite thing to assess. So hopefully more will come out about this, because like I said, I don't think we're just looking at the virus itself. I think there are a lot of components, and some of it is this, what did it cause down the road? And I don't know that we'll know for the next few years, which is why I think the research is so important.
Okay. Well, I think we should end it there. Thank you very much, Dr. Abrams-Silva. Very nice talk, and we appreciate the information you shared.
The only question I have is, do you approve of the report?
Yeah, of course.
Okay, good.
Of course. I like the idea of short reports.
I'm
All
glad.
right. Thank you all for coming.
Thank you.